Hello again. In this video, we will discuss about various articulators and mounting procedures. So let's recap. We discussed about various clinical procedures you need to do in order to fabricate Michigan splint. We discussed about importance of taking good impressions, various ways you can take face-bore records, and take interocclusal records in CR for fabrication of Michigan splints. The next step is you send all this information to technician who will then mount models in CR to the wax up, process the splint, adjust the splint on the articulator, returns the splint back to you, and you then adjust the splint in patient's mouth and then review patient in 1 to 2 weeks time until there is no more further adjustment. So ideally, you will only be doing clinical steps. The middle step, which is done in laboratory, you will not be doing in your clinical practice. However, I strongly believe that if you really want to assess occlusion, you cannot have knowledge or lack of knowledge of how to mount model and how to assess models on an articulator. And because of that, I strongly believe that you need to understand how the models are mounted in CR. What is the difference between mounting models in CR or MI? And once you start mounting your own models, you will be able to understand the quality of your records and reproducibility of the quality of your records. However, if you are just looking to make Michigan splint, you don't really need to mount your models. All you need to do is send technician good set of impressions, face-bore records, interocclusal records. They will make the Michigan splint for you, send it to you, and then you follow on to the next step. However, let's assume that you are interested in assessing patients' occlusion and you would like to mount model by yourself, so then you can assess in your own practice without sending out the work for just an assessment or just a mounting. Because remember, the different articulator, although it's the same articulator, may have a different progressions. They may have a little bit different in calibration. However, newer articulators are much better calibrated, so that if you buy two articulator from the same company, they both should match the mounting, so you can technically interchange the mounting. However, in my opinion, if you want to study occlusion, it's better to mount and assess on the same articulator. So let's see what different types of articulator we have available. So the first type of articulator is a hinge articulator. Now, hinge articulator is very simple articulator, goes up and down, and it's a good articulator to have when you're doing a simple single restoration, which is not 7, it's bounded by 2 teeth, and patient doesn't have too much discrepancy in that bite, and it's a stable bite. And that works very well with this kind of articulator. However, if you would like to achieve a better result, then you can move on to a average value articulator where the values are set. You cannot change those values, but they are set as a normal values. The step up from that is a semi-adjustable articulator where you can change certain values such as condylar inclination, immediate side shift, progressive side shift, and in some articulator, intercondylar distance as well. I most of the time use semi-adjustable articulator and in my clinical practice. One step up to that articulator is fully adjustable articulator. Now, fully adjustable articulator are, as we discussed before, gold standard. However, they are very expensive to maintain, to take the face-bore record for, and very time consuming. And it's very technically challenging skill to have. So if you can do it in your limited time, then fine, but otherwise semi-adjustable articulator works very well in most of the cases. in almost all cases. So let's look at some of the settings you're using on semi-adjustable articulator to start with, which you can change as you need. So the setting you are keeping your condylar inclination is to 25. Now I know many clinicians would like to increase the condylar inclination to 30 to 35. However, the study shows that there is less than 5% of the patient would have condylar inclination less than 25. Almost zero, or very less number of patients would have condylar inclination less than 25 degree. And if you do that, you are creating a barrier where you're not making the inclination steeper than their condylar inclination, and making restorations where then there is a potential to interference. As we discussed in our first series of videos, that if the condylar inclination, let's say, is 45 or in patient's mouth, and you are using condylar inclination in articulator 25, the worst case scenario is the cusps are going to be slightly flatter. However, if you reverse that, if the patient's condylar inclination is 25 and your articulator condylar inclination is 45, which means there is an immediate disclusion, and you will be able to make nice steep cusps and foci and fissures. However, when you put that crown in patient's mouth, there will be heavy interferences. So you want to be on a slightly safe side and have a lower condylar inclination than what patient has. And that's why it's called semi-adjustable articulator, because it really assumes condylar inclination. The other settings which you would use is immediate side shift, which is 0 degree, and progressive side shift is usually capped to 7 degrees. So let's look at some of the differences between average value and semi-adjustable articulator in this practical video. So there are two DINAR articulator I use very frequently. I don't tend to use fully adjustable articulator, so it's either semi-adjustable articulator or DINAR Automark, which has all the settings in there which you cannot change. But as I said before, that I don't tend to change the settings in semi-adjustable articulator. So the settings you get in semi-adjustable articulator is you have a condylar inclination here. That's the condylar inclination. You get progressive side shift and immediate side shift on both sides. Now you have the pin number, and you can have that, you can adjust that, and you can have the same thing in the DINAR Automark. In DINAR Automark, as you can see, there is no guidance, there is no such thing as a progressive side shift or immediate side shift. It's all incorporated within the housing. And what I tend to say to my delegates when I'm doing hands-on courses is that if you haven't mounted before and if you haven't used articulator for a long time, I would recommend to start with DINAR Automark, because that's something will be easier and it will not change. I have to reservice this articulator every 6 months, or if I'm doing very heavy use, then probably 3 monthly, to make sure all the components are fine and there's the plastic sleeve and everything's fine. Whereas this is much more maintainable, serviceable articulator. And hence, as I say, for simple cases, I tend to love Automark. And where I think I need to probably change the inclination, I would use semi-adjustable articulator. So now you know about semi-adjustable articulators. Let's have a discussion about limitations associated with semi-adjustable articulator. By definition, it is a semi-adjustable articulator, which means it's not fully adjustable. So there are things which you cannot adjust completely. And because of that, there will be an error in your mounting, which is inevitable. So the studies done by Clayton in 1971 suggest that if you use fully adjustable articulator, you will have to adjust your restorations 5% of the time. If you use semi-adjustable articulator, then it's 50% of the time you have to adjust your restorations. However, if you use a hinge articulator, it's 95% of the time. And in my opinion, if you try and mitigate the limitations of semi-adjustable articulator, your success rate or the reduction in adjustment is improved massively. So let's look at the limitations of semi-adjustable articulator. So it lacks in adjustment of the immediate side shift, or the fact that we don't know what immediate side shift patient has, and that's why we keep it to 0. It also restricts you in making any changes to posterior superior wall. It's very flat. In many semi-adjustable articulator, you cannot change intercondylar distance, and that is also a limitation. And also one of the main limitations is it's a mechanical device, and you cannot replicate the musculature, the ligaments, the tendons, and all the aspects related to human beings in the semi-adjustable articulator. And that's why you have to be careful when you're assessing these situations. So let's look at one of the first limitation, which is the shape and angulation of articular eminence is not exact in semi-adjustable articulator. Now, because of that, you won't be able to accurately produce the moment the condyle moves in patient's mouth onto the semi-adjustable articulator, because the eminence is curved, whereas in semi-adjustable articulator is very flat. And because of that, if you build posterior cusps, as we discussed before, very steep, and the angle is wrong, then you may start incorporating a lot of interferences. So how would we mitigate that limitation? What can we do is we need to make sure that you're providing patients with provisional restorations, which now you're testing out all the occlusion in the provisional restorations made up on a semi-adjustable articulator. Once you're happy with that provisional restoration, the wear on the provisional restoration, there's no chipping or fracturing, you have checked patient's envelope of function, then you can use anterior custom guidance table and fabricate that and use the same shape in your final restorations. So the custom guidance table helps you in mitigating that limitation. The other limitation patient have is recording of intercondylar distance, whereas many of the semi-adjustable articulator comes with either small, medium or large intercondylar distance. Some of them are fixed, such as DINAR is fixed to 110 millimeter. In these cases, it is very difficult to adjust the intercondylar distance to exact intercondylar distance what patient has. Now, creating customized anterior guidance will also help you in mitigating this limitation. The other limitation patient have is immediate lateral displacement and your inability to adjust immediate side shift. So when patients, as we discussed, move on the working side condyle becomes rotating condyle, whereas a non-working side condyle becomes orbiting condyle, and that condyle orbits forward and downward movement, and it's quite gradual. However, sometimes it moves immediately sideways and then moves forward and downwards. That immediate movement which moves sideways can relate to some interferences if you have cusps which are quite steep on posterior teeth. And because of that, if you cannot really assess that in patient's mouth, you cannot transfer that onto the semi-adjustable articulator. And because of that, you need to make sure that you are again creating an anterior customized guidance, because study shows that nearly half of the patient will have some sort of side shift. Now, it's very difficult to know how much it is. It could be anything from 0.1 to 2 millimeter. So we're trying to guess what kind of limitation we are working with. But if you are replicating the final shape into your provisional and creating an anterior custom guidance table, you are mitigating that risk. Now, the other limitation semi-adjustable articulator has is that you are not recording patient's true hinge axis. You're not recording mandibular hinge axis because you're not using fully adjustable or kinematic facebow. You're using arbitrary ear type facebow, which assumes, as we discussed before, that the axis is 13 millimeter from your external auditory meatus. And that is a limitation. Now, what happens is if you're not on that axis, if you don't have a true hinge axis, then let's say you mounted models. Now, if you're opening and closing that model on an articulator, you can incorporate a vast majority of the errors by opening and closing, because if it's not the same hinge axis in the mouth, then the articulator will move differently than in the mouth. And to mitigate this, as we discussed, what you can do is keep the thickness of your interocclusal records depending on your use of interocclusal records, which we discussed before, diagnostic uses or therapeutic uses. What use are you using for Michigan splint? What is the use you're doing? And depending on that, you keep the thickness of your interocclusal record to minimum. And because of that, you don't have to open or close your articulator and can work on the same level where the models were mounted. And this is really helpful in assessing that. Now, once we understand the limitations of semi-adjustable articulator, we try and negate that limitation by doing mitigation factors. And I hope this is useful for you to understand why you shouldn't rely 100% on just semi-adjustable articulator. All the other steps leading to mounting also is very, very crucial. So let's discuss now what is the difference when you're mounting model in MI, CO or CR. So when you're mounting model in CR, you're really mounting model in CR to analyze the occlusion in CR position, potentially consequences of interferences in CR when you try and close the articulator. It recognizes, it's a recognized approach which is it's needed when you're doing a lot of full mouth reconstruction. However, if you want to really assess the first point of contact, then you need to mount in CO in order to assess. Let's say we discuss the case where we are preparing upper right 7, and that's a CO. The contact is on upper right 7, and when you're mounting model, you want to mount the model in CO to reduce any discrepancies. When you need to mount a model in MI, so when you're doing occlusal assessment, what I tend to do is I tend to have two mountings. One mounting is in CR and another mounting is in MI. because in mounting in CR, you can't really assess patient's occlusion because it's a tooth apart position. Or if you drop the pin down, you will be able to assess probably patient's CO, but you can't assess proper occlusion, what patient currently has, and how patient's functioning in MI. And hence, you need to mount the model in MI to assess current occlusion and their guidance. If you are using conformative approach, then you would also mount model in MI, because you don't want to increase the vertical dimension, you don't want to restore the patient in CO or CR, you mount the model in MI. Now let's discuss a little bit more about mounting models in CR and various steps. So this is the diagrammatic circle of mounting. So first you're going to take Facebook records, you mount the maxillary models using Facebook on a semi-adjustable articulator. You then take anterior deprogrammer and take some interocclusal records and then mount mandibular model using those interocclusal records in that position, which is CR. When you mount the model, you really need to verify that your mounting is accurate and the findings you found in patient's mouth matches on the articulator. So verification is the key in my opinion. And when you're mounting models, you need to check for seating of the models, maxillary mandibular, such as this, where you can see that the models are really matching the impression we did using Tambon. You also want to check your anterior stop which you created is aligning with your mandibular model, and we will discuss this in detail. We discussed this in detail when we discussed about interocclusal records and how to take interocclusal records. So when you are taking these interocclusal records, you are really checking on the mounted model that it matches the same as in the mouth. If it doesn't, you will have to go back to drawing board and you have to remount the model. You also can check using shim stock whether your CO matches in the mounting what matched in the patient's mouth. If it doesn't match, then there are lots of variables you have. You could have wrong mounting, you can have wrong records, you can have everything right, impression, records, mounting, but your clinical assessment time, you could not manipulate patient's mandible or jaw backwards enough to get a true first point of contact. And now what you assessed clinically was the wrong first point of contact. So at this stage, you need to really assess whether you want to give patient Michigan splint or you want to progress with restorative treatment. I personally would not progress until my mounting is verified. And I usually mark the models and make sure that the mounting has verified. Now this technician should be doing this. Once the technician's done that, then they will perform laboratory procedure, various steps in order to, with the flasking, mounting and adjusting Michigan splint, refining and sending back to you. So once you know, now you know all the steps relating to mounting and articulators, let's look at some practical videos on how to mount models in CR, how to mount models in MI, and the difference between mounting in CR and MI. So once you have gathered all the information, you will need these materials to mount your models on a semi-adjustable articulator. So let's look at the semi-adjustable articulator first. So we have a Dinar semi-adjustable articulator here. To be honest, I do not, as we discussed before, adjust the settings too much or too often. I would say rarely I would adjust the settings. I would keep the settings to the minimum, and we will go through within the lectures what settings I keep regarding condyle inclination, immediate side shift, progressive side shift. However, if you get the articulator, which is all the settings are done in DINAR, then you will be still fine. As far as you have some sort of articulator which you can relate your Facebook to. Now, DINAR is not the only articulator you can use. There are other KO articulators, there are very fancy articulator available. However, this is what I use, and this is what I'm going to go through with you today. So first of all, for mounting, what you need to do is you need to remove the top bit of the articulator by using this chip here. So you click and that comes up, and then you would take the top bit out. When you take that out, you will be able to see the condyle inclination here, which I've kept to 25. Inside here you will have the numbers, progressive side shift, and then here you will have immediate side shift around here. So I would keep immediate 0, progressive around between 5 and 10, so it's around 7-ish. But make sure that they both are same. Make sure that the condyle inclination on the both are same, because what happens is sometimes when you use this often, sometimes it can get changed. So what you can do is you have a screwdriver which you can use to tighten the keys, all of them. But make sure they are all tightened, and there is no way you can it moves. In here you have these two keys for the condyle inclination, so you can tighten them. Sometimes in other DINAR articulators you have similar keys, and you can use the driver to tighten them. Once you know that your settings are fine, make sure that you have your marking here set up to 0. So I'm just going to set that up to 0. That's done now. The next thing you need to do is you need articulating sort of a mounting plate, which you need to position on the articulator and then screw that in. Same thing for the lower component. So that's nicely tight. Make sure it's tight, otherwise you might have an issue where it's loose, you mounted everything and then your mounting is wrong because you didn't tighten them properly. That's a very easy mistake to do, so just make sure they are nice and tight. Now once that's done, you will need obviously your maxillary and mandibular models. You have your Facebook. Now this is a mounting table which you will need in order to use a Facebook to mount the model. So what you need to do is you remove the normal table here and put the mounting table. So this part here, you can see there, that goes into it. Make sure it's seated here completely, because here you will see that it doesn't look like it's seated completely. However, this is seated. So what I would suggest is you look at the backs of the articulator to make sure it's both are seamless here and here. Okay. Now you tighten this, and that's done. Once that's done, you will need to use your Facebook, and the part here that will go should slide through in there likewise. Okay, once that's slide through in there, I'm just going to use this and I will tighten that. Once I'm happy, I'll take the maxillary model . I have already verified to make sure it fits fine, so I don't need to worry about it. I'll keep it like this and I will check whether my model, my articulator, the top part of the component fits fine. So I'll just press it here and then the latch at the back, I will just do that. Now I'm going to check the height to make sure how much height I have and how much articulating plaster I need to use. Okay, I'm going to undo this because before you would start mounting, you need to create some grooves on the model just to get some roughness. You can use straight handpiece, you can use just the knife to just create some scores, and make sure you make this a little bit wet. The reason being that when you use a stone or a plaster, if this is dry, it will remove the water from the plaster and then the plaster may not set properly. So literally just do scoring. So that's done. Okay, so once you've done that, you need a wet tissue and you can just put it on top just to make sure that the model is nice and wet. Okay, you don't need to put the model into the water because otherwise you can have issues with the articulating surfaces, your teeth can start abrading. So you just want to literally gently drop a few drops of water and make sure it's nice and wet. Okay, you don't want a puddle of water, but just a tiny bit of that will do. Once that's done, you need to get some water in the bowl and start mixing the plaster. When you're mixing the plaster, you need to make sure the consistency is very runny. It's not very hard. The reason being that if it's really hard, it will produce a lot of heat while setting and it will expand. So all the plaster expands as we discussed, and what happens is when they expand, your mounting can get affected. So make sure and these takes some time to set, so you have plenty of time to work around it. So no need to panic. Because you have mixed a runny mix, it takes time for it to set. Then I'll carefully put this on top of the model, and then don't forget to place the latch on. And that's done. Your mounting is done. We wait for a few minutes. While we're waiting, it's a good idea to clean the bowl with the tissue because you don't want to chuck this down the drain. Otherwise you will have issue with blockage of your draining system. Now this is starting to set a little bit, so I'm just going to use my fingers to just make it a little bit tidier. I have deliberately used less plaster because the more plaster you use, you get more expansion, which you don't really want. So you just want the minimum amount of plaster. Now that will do, and we now let it set. Do not touch. You don't need to put anything on top or anything like that, because you mixed a really runny mix. It will set perfectly and it will not expand massively. Okay, so it's been around 20 minutes. The plaster has set. I'm just checking the temperature, and it's not hot or any warm. So it's all nice and set and nice and cool. So we are ready now to take this apart. So again, I'm going to use remove the central latch, open it. I will now take the Facebook record out because we don't need it anymore. We don't really need this mounting table either, because that was there to hold the Facebook record. So I'll take that out and I'll use a normal table back again, because this is much easier to deal with when you are assessing, evaluating models. Okay, so I'm just going to check whether it's fitting properly again on the side and on the bottom, and make sure it's nice and tight. I'll check again all the plates are nice and tight. I will also check whether it's at 0 and if there is anything shifted, all the angulation and alignment. Because now this is very crucial bit when we are now going to articulate mandibular model to the maxillary model. Now to do that, I will make this upside down, likewise. I will now put my Lucia jig, if you've used Lucia jig, and the records you took, make sure that it fits fine. So that's seating really well, and I can see that it's nice and tidy there. And I will then put my lower model so that I can align it. And it's nicely aligned. It sits really well into the groove we made, and you can see here really well, the seating really well all the way around, and more importantly, I can see that the incisor is locating on the light body, flowable composite we placed really nicely. And there is no space, there is no movement. So I'm very happy with this, the way it's looking. I'm also checking if it's wobbly. So if I put too much pressure, it wobbles here, but otherwise it's not too bad. As far as it's stable within there, it's okay. If it's wobbly, then you really need to, if it moves a lot, and if it's not stable position, then what you will have to do is when you're mounting, you'll have to hold the model down until the plaster sets or setting. So maybe 5 minutes or so nicely solid. Otherwise, if model mounts like this, then your mounting will be wrong. but here it seems pretty stable. Okay, the next thing I'm going to check is how much space I have. So I'm going to do this and then lock the latch grip, and you can see we'll need a lot of plaster there. It's not related to anything really. Sometimes the thickness of the model is more, you need less plaster. It's just the way the mounting is. So you don't need to really assessing that in regard to accuracy of your mounting. It's just you need to know how much to mix. So I'm going to take this off again. I've already created grooves and I've already wetted the model from the base. So now we can just go ahead and mix plaster. I've taken a bit more water, so because I know that it's going to take us a little bit more plaster than the upper model. Again, make sure it's fairly runny consistency. And you can see if it's too runny, what you can do is you can either wait or add a little bit more plaster, but just make sure it's not too thick. If you want to wait, then what I would suggest is you put the plaster onto the mounting table first, because there is no stone or anything there, so it won't affect the setting time. But if you put it on there, it will set a bit quicker on the model. But we have consistency is not bad, so I'm just going to put it here. The other way you can check whether you have built enough or not is when you are looking at this level here. Okay, so you will know that you got enough if you go slightly higher than that. If you don't have enough, you can do this in 2 stages, so don't worry if you try and put the model in and then it's not really enough. But in our case, we have enough there, more than enough. Now what I'm going to do is just take excess off, just to make it tidier. I'm just checking whether my models are stable, the latch is closed, and everything looks fine. So I'm going to leave this like that for 2-3 minutes until it gets a little bit more harder, and then I'll tidy up a little bit more. Okay, when you're tidying up, make sure you hold the model and then tidy up so that it doesn't move really. Okay, now we'll just wait for this to set properly. Now we're going to assess the mounting, and let's have a look whether the tooth we decided during the clinical examination, which was lower right 8, upper right 8, which was in contact with the first, and you can see that it's really, I'm pulling hard and it's not budging, so that means it's that's the contact and model has verified. And then what you can check is still, is there any other contact you see is getting, there is no other contact apart from that tooth which is here, lower upper right 8, and that's the one we're going to assess. Now we can, if we want to verify, we can use the articulating paper and literally put it on there and get the contact and have a look and see whether it's verified or not. And you can see that there is a contact on the palatal cusp of the 8, and that's what we are looking for. So the model is verified. Once that's done, what you can do is you can start assessing the model by holding it and trying to put them in ICP. And the way you do that, you will be able to see the slide, and you can see here how the jaw moves and slides forward, and you can assess the amount of slide, and you can assess how much slide is happening. Afterwards, what you can do is you can start taking the first point of contact away, and then you can assess where else the contact is going, and you should be able to then assess the restorability of the area, and you should be able to assess, if you take that wisdom tooth out, which tooth will take the pressure. Okay, so sometimes you need to mount models in CO or CR, but most of the time you will be mounting models in ICP, and many times people get confused what you need to mount model in CR and what you need to mount model in ICP. To mount model in ICP or MI, you only need face bow for the mounting of the upper maxillary model, which we have already done. So we've used this face bow to mount this model. Now, for mounting of the lower model, all you need to make sure that when you're putting two models together, you can hand hold these models and it's not rocking. So I tend to put it like this and make sure the model is stable. And that's it. That's all you need. If the model is not stable, then you need to figure that out during your examination stage. And what you can do is, wherever there are gaps or some edentulous areas, you can either use putty or you can use bite registration material. Just avoid using bite registration material or putty wherever the teeth are in contact, because that's when you will know whether your model is seating properly or not. And this is another thing I've noticed, is when you are doing crown preparation, if you're doing 2-3 crowns and if they're bounded by teeth, and if you're mounting model in ICP, you don't really need to take a bite registration if you have a good set of teeth. If there's a posterior teeth missing, then I sometimes request bite registration wax or something, where I could take a bite registration while doing records for ICP. But in this case, the lower model, lower model is sort of pretty stable. Is going into the upper model very well. So now I will just assess as normal the height, and I will start mixing the plaster and mount the models. So I've mixed the mounting plaster. I'm just going to put some on the mounting plate and some on the model. Okay, and we leave it now to set. So now this mounting is ready, and as you can see, this is in ICP. So if you want to assess patient's lateral excursion or guidance in the current dentition, you need to mount model in ICP. So what I tend to do is I have a same maxillary model, and I have two lower models, and one model will be mounted in ICP, as you can see here, and then I will have another model which is here, which is mounted in CR. So then I have two lower models, one mounted in CR, one mounted in ICP, and because the maxillary model in both situations needs face bow, I will just have one upper maxillary model which is mounted, and I can swap the models. Now, many times I have two maxillary models mounted, so I can use two articulators simultaneously, so I don't have to take models out and in and out, and that helps. However, if you have just one articulator, then this method suits very well. So as you can just see, again, this is ICP, and the teeth, when you latch, put the latch on, the teeth are in contact because patient did have a stable ICP, whereas we swap the model. When you are putting model, you do need to make sure this is really nice and tight before you assess. And this is in original mounting because we had a bite registration in between, so this is basically a tooth apart mounting at 0 mark. Now, what you can do is to assess this slide. The other thing is you can drop the pin down until the first tooth in contact, and then see the ICP and then check what is the distance. However, this is not a millimeter. It's approximately, but it's not exact millimeter. It doesn't replicate same here to there. But basically, this is now a mounting. Because I've dropped the pin down, so I'll literally remove the pin, and the model is now contacting on lower right 8, which is CO. So this is now becomes a mounting in CO. Whereas if I lift this up a little bit, then this is CR. Now, you need to really understand that the articulator are not an exact science. So the CR, if you're doing teeth apart position, then if you're relying on CR, then the best ideal CR would be the CR you mounted the models in. So when it's 0, this is the ideal CR, and this would be more or less replicated in patient's mouth at this level. However, if I'm moving the pin up or model up or down, then it is not exact replication because the jaw doesn't move up and down like this. It goes sometimes sideways, so it may not replicate same. And that's why when you are mounting in CR, you need to really first understand what is the reason you are mounting. If you are mounting for Michigan splint, then keep this 2 mm distance. If you are mounting for diagnostic wax up, then you need to really keep this distance, the space, approximately the space you want to create or recreate in patient's mouth, because then the mounting will be most accurate. If technician has to open or close articulator, then the mounting may not be as accurate. So something you need to understand where you're mounting. And I hope it makes you understand the difference between ICP mounting and mounting in CR. So I hope after looking at this mounting procedure, you understand the importance of knowing how to mount your own models and how it can help you in verifying your mounting, especially for those crucial full mouth cases where you're about to restore a patient's teeth and your mounting needs to be verified. And also it will help you in making a good patient occlusal assessment. In the next video, we will discuss about how to fit and adjust Michigan splint.